Good evening, everyone. Thank you so much for joining and making time to listen to my presentation. Like Dr. Beatty Santon said, my name is Moyo. I'm currently at the tail end of my community service year. I was at Rahima ED for the first 6 months, and now I'm at Helen Joseph ED. So today I'll be talking about malnutrition in children, specifically in our context, which is South Africa. Now, although it's not a primarily ED topic, it's not the first thing that comes to mind when we think of pediatric emergencies, but it's still really important because we see it as a comorbidity in a lot of our children. We have a very impoverished community, and so it's important to be aware that malnutrition is a significant burden of disease for us. And I have tried as best as possible to put a bit of an ED spin on it. So I hope that you learned something. Okay, so I'm going to start with a little case presentation. So Kanya is a 14-month-old boy, and he presents on your shift to the ED. His mother Joyce brought him to the hospital complaining of a chronic cough, and now he's not feeding well. You notice clinically that he appears a bit irritable. He looks quite thin overall, and you also notice that his feet are swollen. You take a full comprehensive history and you plot his anthropometry as you start your examination, and you discover that he has a weight for length of -3.2. Okay. So before we dive in, I'm just going to start by giving some definitions. So malnutrition refers to deficiencies, excesses, or imbalances in the intake of energy and or nutrients. And the term addresses three broad groups. So undernutrition, micronutrient-related malnutrition, and overweight and obesity. So typically when we think of malnutrition, we only focus on the undernutrition. We think of the tiny little Sam baby or a stunted child, but it also encompasses overweight and obese children. So it's important not to overlook the very cute, chunky toddler that you think is just nice and squishy. It's important to realize that being overweight and obese as a child is still a significant comorbidity, and it's actually an increasing problem in this country. So undernutrition encompasses stunting, underweight, and wasting. Micronutrient-related malnutrition includes micronutrient deficiencies or micronutrient excesses, which is more rare. And then being overweight and obese is having excessive nutrient intake, but over a prolonged period of time. And so these three things represent kind of the triple burden of disease when we think about malnutrition. So these are our anthropometry chart. You can see, I'm sure we all recognize this from the Road to Health card. And each of the lines kind of delineates a different Z score. And so when we plot our kiddies, this is how we plot them. And we have definitions that also, or we have numbers that define the anthropometry. I'm just going to define them. So basically, these are the Z scores. I'm not going to go through each of them because I'm sure we have a broad sense of like the numbers. But basically, I want to focus on the MAM and the SAM. So a weight for length, Z score of -2. So that's below this orange line that's second to last at the bottom, or a mid-upper arm circumference of 11.5 to 12.5 constitutes a MAM. Now the mid-upper arm circumference, you can either just use your standard non-elastic tape, or sometimes there's a specific MUOC measuring tape that has colors that delineate whether it's normal, a MAM, or a SAM. And so if it falls in between those ranges, then it's a MAM. A SAM is a weight for length or height less than -3, so that falls below the red line. Or it's a MUOC of less than 11.5, or bilateral pedal edema. So it's important to realize that it's any one of these, not all three necessarily. So you could have a kitty that has a mid-upper arm circumference of 11.5, or I mean like 11.7, so that's just above the cutoff. But if they have bilateral pitting edema, specifically on the feet, then it's indicative of a SAM unless proven otherwise. So any of the criteria make them a SAM, and then the overweight and obesity is above the +2 or the +3 line. Okay. So this diagram shows the causes of under 5 mortality in our country. And as you can see, malnutrition is the little orange sliver there that I've highlighted. And it looks like quite a small percentage in like the grand scheme of things, but that's because this percentage only represents an immediate or direct cause of mortality. So malnutrition only accounts for about 4% of under 5 deaths, but that's as an immediate cause of death. So that's the terminal event only. SAM, or malnutrition in general, is actually an underlying cause of death for 1 in 3 child deaths in this country, which means that about 30% of children have malnutrition as a comorbidity that is contributing towards the terminal event, or maybe even started the sequence of events that lead to the immediate cause of death. So we can see that it's actually a significant percentage, and that's why it's a really important topic to know and to be able to address. These are some statistics. So we can see that in our population under 5, about 27% of children are stunted. So that is a low height for one's age. 6% are underweight, and only about 2.5 are wasted, which I was a bit surprised at. I thought that that statistic would be more. But 13% are overweight. And I think that that highlights the fact that obesity and being overweight as a child is more of an issue than I think we give attention to. And it's a rising problem not only in South Africa, but in a lot of first world countries as well, because of the diet that we now have and the sedentary lifestyle. So it's important to keep an eye out for the bigger kids as well. Okay, so the risk factors and causes of malnutrition are almost never straightforward. It's almost never one-dimensional, especially in our context, where there's a lot of social issues and there's a lot of poverty. So it's very multi-layered, it's very complex, and we can see here that it involves basic and structural as well as underlying factors that contribute towards food insecurity or contribute towards children being malnourished. And the reason it's important to be aware of these is because if we aren't aware of them, we won't address them. And if we don't address them, or at least try to, then children inevitably end up where they started, and you'll end up having them back in your care as a SAM or a MAM if you don't try and address these underlying issues. So I know as healthcare workers, we want to be heroes, but unfortunately we can't solve everyone's problems or all the social issues in the world. But at least if we're aware of the fact that maybe a mom doesn't have a grant when she's actually eligible for one, or there's massive food insecurity and there's a non-profit that we can connect her to, we are at least trying to alleviate those factors. So it's just important to be aware of them. It usually isn't just us involved. We usually need different sectors. It's a multidisciplinary team approach. We talk to social workers. We talk about grants, but it's important to be aware of all of the things that contribute towards malnutrition. This slide is it's actually called the UNICEF Conceptual Framework of Malnutrition, and it basically just shows what I was chatting about in the slide before in a nice structured diagram, and it shows the layers and the risk factors and how multifactorial they are, and it's just a nice visual representation of the slide before. All right, so moving on to clinical presentation. The biggest takeaway here would be always check and plot the anthropometry for every child. and that regardless of what they're coming for, regardless of the presenting complaint, regardless of what they look like as well. So most children or most caregivers won't present with malnutrition. They won't come to you and say, oh, my child is malnourished, or oh, my child looks thin. They are usually presenting for something else completely unrelated. So gastro, or a cough that isn't resolving, or maybe now they realize that their child is feeding poorly. But if you don't look and you don't check and you don't weigh your child and you don't do the height and physically plot, you will miss it because it's not always obvious. So we also plot not just because we're trying to pick it up, but also so that we have a trend. Data points mean very little in isolation. So if I see a kitty today and they have a Z score of just above the -2 line, technically they're normal, technically I'm happy. But if I see a trend that they started at, above the +2 line, and now I can see that they're dropping, Z scores very acutely, or there's a sharp turning point, it kind of raises a red flag that maybe there's something going on. Why is this kid now losing weight? Is there something that I should be aware of? Because we want to catch these things before they come a MAM or before they come a SAM. So it's important to look at the trend of the growth. And malnutrition isn't always obvious unless it's quite severe or advanced. And at that stage, we don't want it to get there. So even if the child looks okay, maybe looks a little small, always plot, because you'd be surprised how often they actually do plot below what you thought. So it's often missed because we don't always look for it. And I know it's hard when the ED is busy and now you must drag this little child to do the height and plot them, but it's really, really important because otherwise it goes unnoticed. So in terms of the history, I'm not going to go through everything, but like I said earlier, they could present with any kind of acute problem, from a gastro to a chronic cough, to decreased appetite, poor feeding. It could be an array of things. The last one, their developmental delays or regression, is quite a late and ominous sign if it is caused by the malnutrition. So if that's the case, it's already pretty advanced for that child, but it's just to keep at the back of your mind that there might be something else going on. Okay, so in terms of our clinical signs, once you've taken your history, obviously the first thing you do is you weigh your child, you do the height, you plot the anthro, and then you start by looking at your child. Start with vital signs. So SAM kitties or malnourished kitties can come with usually normal vital signs, but they may have hypothermia because they're losing their fat stores. They may have hypoglycemia. That's an important one to be aware of. Usually if they're coming for something acute, they'll have a bit of a tachy response. But if it's very late, a Brady is possible, but that's usually quite a late and ominous sign. And then we need to start thinking of resus and that kind of thing. But most of your signs or your clues lie in your general examination. So if you think about your CAG cold or your JAK cold, look for the anemia. So look for pallor, and importantly, look for the edema. It could be in the feet, it could be in the abdomen, it could be could be in the face. Sometimes they have these very chubby cheeks. It could be anosaka, but make sure not to miss edema. Make sure not to miss a SAM kitty that's just quite swollen because they don't obviously look thin. And then a lot of clues lie in your in the skin and hair. So they'll have this kind of very sparse, very thin, deep pigmented hair. It looks like the sandy brown color. Their skin, they call it like a dermatosis. It might be flaky and peeling. There may be areas that are deep pigmented and hyperpigmented. So those are the kind of changes that you'd see. In the abdomen, they may have quite a big belly despite the extremities being quite wasted. And it's important to also look for a HEPA because they often have fatty liver infiltration. But after doing a general examination, you're obviously going to examine every system, especially the one pertinent for the presenting complaint. So if they are coming with increased work of breathing under stress, you're going to make sure to focus on your rest exam and things like that. But these are the general signs for a malnourished child. Okay. All right, so in terms of treatment, I'm sure we all know about the World Health Organization 10 steps for the treatment of malnutrition. So here I've got steps 1 to 9. The last step is preparing for discharge. So it's divided into 2 phases, the stabilization phase and the rehabilitation phase, which are pretty self-explanatory. In the first couple of weeks, we just want to stabilize the kitty, resuscitate if we need to, and thereafter, that's when we start trying to catch up growth and getting the kitty back to baseline. So a lot of this happens in the ward. We'll hear about F75 and F100, but we do have a role in the ED, and our role kind of lies between the first 5 steps. And this is where we come in, because when they present, they obviously don't go straight towards 17. They usually come by us. And so it's important that we have an approach to handling the first part of the stabilization phase. And this is how we do it. In the ED, we love the ABCs. And so that's what we stick to essentially. Remember, there's usually an acute problem. So a gastro kitty who may be shocked now, or a kitty with a bad pneumonia that's now very distressed and working very hard, maybe even hypoxic. So very often we're going to actually have to do a thorough head to toe and then resuscitate and stabilize our kitty before we can even think of the malnutrition or the SAM part of it. And so we do that using the ABCs. So you start with your airway. If there's a kitty and they have severe stridor, or you think there's a croup, obviously you're going to try and maintain their airway. You're going to try and make sure that it's not compromised. The same goes for B. If they're working very hard, if they're hypoxic, supplement oxygen. The circulation is an important one because we have to be really cautious with fluids in malnourished kitties. So even in our EML or guidelines, you'll see that when it comes to resuscitating a shocked kitty, let's say they've come in with a severe gastro, they're now shocked, we have to be really careful about how quickly and how much fluids we give. So if a normal child would have had a 20 ml per kg bolus over 5 minutes, for a SAM, we'd actually want to do about half of that and do it over a longer period of time. So start low and go slow with the SAM kitties, because they can easily be pushed into overload, and you don't want to worsen an already compromised child. So if they are shocked and you see that they need a bolus, by all means do it, but just go slow and with a smaller amount, and then make sure to reassess after each bolus. So after you've done the bolus, listen to the chest, see, are they now clinically worse, which means maybe now we've given too much fluids, are there now crackles, have we now overloaded this child? So it's really, really important to be cautious with the fluids with a malnourished child. Then D, don't ever forget glucose. Hypoglycemia is one of the most satisfying things to treat. So if the sugar is low and we can replace it IV, make sure to do that. And if it's not, then make sure to prevent it by giving the child something to eat, letting mom breastfeed if the child can tolerate food. So that's D. And then E, we obviously do our head to toe. We look for anything obvious. Is there a rash? Is the child very hot to touch? Pyrexia, are we thinking that there might be some sepsis on board? And if there is, then we give antibiotics. And so we can see that just by going through our ABCs, we end up concurrently actually addressing the first 5 steps of the WHO 10 steps. The last one there, the electrolytes, in the ED we usually only replace if it's very, very severe, to the point where it could now compromise like your cardiovascular system or something. But if it's a mild electrolyte abnormality, usually we leave that for peds to sort out. And so once we've stabilized our kitty, we've actually done the first 5 steps. And those are really important steps. And then thereafter, once we've stabilized them, we make sure to continue whatever management we've got going on for the acute issue, and then we can refer them to peds to do their thing in the ward. I'm just going to chat a bit about what to do when you don't have someone to refer to, because there are settings where you are ED and you are peds and there's no ward 17 to refer to. So in that case, once your child is stabilized, and if they can, it's important to feed the child as soon as possible. And what we give is F75. I'm going to chat about it in the next slide. But it's basically a formula that we give with a specific amount of calories, and you start that as soon as possible if your kiddie can tolerate it. So if there's no contraindication to giving food, like they aren't super distressed or vomiting everything, then we start F75 as soon as possible, and we give it every 3 hours. Okay, so this is F75. It's a special therapeutic milk, and it's designed to treat nutrient deficit in the SAM kiddies, especially those with medical complications. So it provides...
Hi, Moyo.
Hi.
I think we might be hung.
So this is F75. It's a special therapeutic milk, and it's designed to treat nutrient deficits in the severely malnourished children, especially those with medical complications. So it provides approximately 75 kilocalories per 100 mils, hence the name. And it's got a special composition. It's low in protein and sodium, but has adequate glucose. And this composition is intentional because it's used in the stabilization phase, and it prevents refeeding syndrome. And that's a life-threatening complication that happens when we rehabilitate too aggressively. And that has its own set of complications. So we want to avoid that. We start with F75, and then after a few weeks, once kiddie is stabilized and tolerating F75 well, then we transition to F100, which has higher calories, and that's what helps the catch-up growth, and that's what helps them put on weight. So it's technically like any other medication we would prescribe. It's only given in a hospital setting. We don't give this as an outpatient. And it's given every 3 hours. It's written on a script, and we should be giving it every 3 hours as, you know, like a drug. So that's the F75. Okay, I'm going to touch on CMAM, Community Management of Acute Malnutrition. So basically, it's a decentralized approach, and it shifts the management of acutely malnourished children from facility-based to community-level treatment. And it's often provided by primary health centers or your mobile teams. And so the World Health Organization recommends CMAM, and it includes a number of things: screening of acutely malnourished children, outpatient management, providing ready-to-use therapeutic food, and then for the children that we see are severely malnourished or they have medical complications, referring them to hospitals for inpatient management. The IMCI also promotes CMAM. It has sections on malnutrition and how to prescribe ready-to-use therapeutic food, and it's really improved the outcomes, especially in rural areas. So this is our ready-to-use therapeutic food. I'm not sure if everyone's actually seen it, but this is what it looks like. It's really revolutionized the treatment of malnutrition, especially from a community point of view, because it allows caregivers to rehabilitate their children at home, which is really important. So it contains important macro and micronutrients. You can see the ingredients listed, and it has sufficient calories to catch up growth. So it has 500 calories per sachet, and we give it for the children that can be treated as outpatients, which are your MAMs or your SAMs that don't have any medical complications, so long as they're older than 6 months. And it's got a lot of benefits because it has a really long shelf life, so it's not going to expire easily. It doesn't need any special storage. It doesn't need to be refrigerated, and it can be eaten straight out of the sachet. You just tear it, feed it to your kiddie. It doesn't need any water or preparation. which means it's very accessible. And this has really helped the movement of CMAM. And lastly, we're going to touch on prevention, because we know that prevention is always better than cure. And so the evidence for how to prevent malnutrition is really well established. It's a very, very, very preventable condition. And we do it using a combination of interventions and programs, nutrient-specific interventions and nutrient-sensitive interventions. So nutrient-specific interventions address the immediate determinants of fetal and child nutrition and development. So they address things that have direct impact on food or nutrition. So think about exclusive breastfeeding for moms, food diversification, micronutrient supplementation for mom and baby. And then nutrient-sensitive approaches influence underlying determinants of nutrition. So they have a wider scope and we involve a variety of sectors. So the health sector, agriculture, social development, water and sanitation. So think food and agricultural food security, promoting maternal mental health. And this kind of ties into those basic and underlying risk factors that I was chatting about earlier. So that's kind of where that is aimed at. And using a combination of these interventions, we really can prevent malnutrition in our community. Okay, so to wrap up, the take-home points, malnutrition is not only undernutrition. I know we only think of the wasted little child, but it's important to also remember the other end of the spectrum, the obese kiddies, the overweight kiddies, because that's also a significant burden of disease. Like we just talked about, it's very preventable as an immediate and underlying cause of death. It is often missed if you don't look for it. In terms of treatment, we need to stabilize or resuscitate if necessary and then rehabilitate. And we always want to reintegrate the patient and their family back into the community as soon as possible. Okay, that was the last slide. Thank you so much for listening, and are there any questions?